Congenital malformations in children is a common thing that we see as pediatric surgeons, and not every time it is possible for us to diagnose antenatally, but often they're diagnosed antenatally, and we'll be able to tell. And today we are going to talk about anorectal malformations, a pediatric surgeon's role. In anorectal malformations, in antenatal period, very difficult to diagnose. The only thing that they'll be able to tell is the intestines are dilated, and because there is a block in the intestines, the mother will be showing a polyhydramnios. Apart from this, it's very difficult to diagnose antenatally. So today we'll talk about actually a pediatric surgeon's role in anorectal malformations. So anorectal malformation, is it all about one anus or is it something more? So it is not only about creating a new anus, neo anus, what we call. It is about the continence the child is going to have lifelong, and it is about the urinary tract infections if the child is going to develop because of this correlated things. And what are the renal anomalies which are associated? Are there any cardiac anomalies? Are they need to be addressed properly? And skeletal issues, if at all, if noticed, and there are then renal anomalies, limb anomalies, or what are all the psychological aspects actually that we should understand. So today we'll go through in short about all these problems. So anorectal malformation can be of various types, various classifications are there. Simplest one is it an imperfect anus? Anus is not there at all. Is it a covered anus? There will be a small opening will be there, which will be almost like a covered anus, or something called as a bucket handle anomaly, or it can be seen only as anal stenosis, where it is very narrow, but it is there. So all these types actually will come under low anorectal malformations. And sometimes the anus will be slightly anterior. That is what we call it as a anterior ectopic anus. And after all these things, the constipation can be developed because of the post-operative stenosis also. So all these things need to be understood. Terminology need to be understood, and we should be aware of these things. We'll go through a little bit about into the details about the anorectal malformation. Coming to the anorectal malformation, actually, like I said, actually it can be imperfect anus or it can be a fistula. So especially in boys, actually they'll be having what is called as a fistula into the urethra. So from which it will be emptying sometimes. So sometimes it will empty, sometimes it may not empty. And in females, usually the fistula will be within the vestibule. So if it is within the vestibule, it will completely slowly start decompressing. So that's why after second or third day, by second or third day, a girl will be decompressing even if it is having a anorectal malformation. That is how sometimes they go unnoticed and missed. And there are some associated anomalies also along with the anorectal malformations. I will go through in detail about these things in the coming slides. So there are terminologies about actually CTPL or invertogram, which is an X-ray which is done after 24 hours, and that is when we'll decide actually what we should do with this baby. And along with that, actually, we'll do an ultrasound of the kidney ureter bladder to see if there are any renal anomalies, if there are any ureter anomalies, or if any bladder issues are there, urinary bladder issues are there. And how we are going to treat actually a low one, actually, it is a single treatment, that is anoplasty, that gives a very good result cosmetically and lifelong, a simple corrective procedure. And if it is a high or an intermediate anomaly, actually we'll be doing a staged operations, which I'm going to talk about in detail in the coming slides. So overall, the follow-up is mainly to see if the child is going to be continent lifelong, or is the child is going to have some constipation along with that. So both are equally important, a constipation and continence, though both lie in the extremities, both are equally important. Coming to the association, there are several associations and fancy associations which are associated with the anorectal malformations, but we'll talk about the most important ones, which is the vacteral or vater anomaly. Vater or vacteral, it talks about the V stands for vertebral, A stands for anorectal malformations, and C stands for cardiac anomalies, and TE, tracheoesophageal anomalies, which is usually esophageal atresia or tracheoesophageal fistula, and it can be R is for renal kidney anomalies, or sometimes it can be radial anomalies also, and limb defects. So this is what actually Vactral says. So if at all, if three of these seven problems are there, then we can call it as a Vactral association which is there. So this is seen rare, and it will be seen in anorectal malformation will come to around 1 in 10,000 to 1 in 40,000 of the newborns. So in girls, if at all, if we want, actually we can add what is called as a vector GRL else. So in this G stands for gynecological, actually it will stand for abdominal pelvic ultrasound, or we have to do a vaginoscopy as when this is required. And S stands for spinal anomalies. It can be comes under actually vertebral anomalies also. The vertebral, what we do, the tests what we do for all these things here, vertebral to check, we do what is called as a babygram, infantogram, or specifically if we want, actually we can do a sacral or chest and X-rays to see if any thoracic defects are there. Anorectal examination we can diagnose by an physical examination only. And if it is a cardiac anomaly, we can do a 2D echogram. So to see if what is the exact structural anatomical defect which is there. And tracheostomy fistula, by passing a feeding tube and taking an X-ray, we'll be able to tell if the child has gotten a esophageal atresia or not. And gynecological, I said actually by doing ultrasound and genitoscopy or vaginoscopy, what we call. Renal anomalies, actually we'll see if at all, if there is abdominal, by doing abdominal ultrasound, we'll be able to clearly make out if any associated problem is there. Or sometimes late phase, we do what we call it as a micturating cystourethrogram, that is MCUG or VCUG, voiding cystourethrogram. That will tell if the child is having a vesicoureteric reflux, where the urine is coming out of the bladder. Instead of going down, it will go on to the kidneys. That's what is called vesicoureteric reflux. So limb anomalies, actually in the FAME in babygram that we do, actually we'll be able to see if limb anomalies are there. And spinal anomaly, sometimes actually if spina bifida or something associated, we can do it by doing a spinal ultrasound. So initially, after the baby is born, what are we going to do? Actually, any pediatrician, any newborn specialist, actually, what they'll do is actually they'll pass one NG tube in the orogastric just to check if it is going into the stomach, and same tube actually we can take and put it in the anus to see if there is meconium staining on the anus. Just by passing into the tip is not enough. We have to see the meconium staining. So we'll pass the feeding tube in the, if it is not going beyond 10 centimeters, then maybe we'll be suspecting is there a esophageal atresia or a tracheostomy fistula. Then we'll get one shoot one film of X-ray chest to see if there is any coiling in the upper esophageal portion. That is when which confirms esophageal atresia or esophageal maldevelopment is there. So some, and along with that, I told earlier that we'll be doing what is called as a babygram or an infantogram, where in one single frame, actually we'll be putting the baby with the head to toe. Actually, we'll be seeing the full radiological evaluation, and we'll be getting one assessment. And along with that, we'll be doing one ultrasound, and then actually we'll be doing. I said actually in the previous time, I said actually we have to wait for 24 hours, first 24 hours. We won't do any procedure till for first 24 hours in a boys especially. That is because in the 24 hours, actually whatever aerophagia gas which is swallowed by the baby, it will start going down, and it will go up to the lowermost part of the anorectum. Then we'll know actually what level it is going and what level did not form. So to check that, we'll wait for actually at least 18 to 24 hours. But usually most of the people wait for 24 hours. Then we'll do what is called as an invertogram or a CTPL. And there are various types of anorectal malformations from starting from the male, starting from the female, and various anomalies will be there. In these various anomalies, actually, what we can see is here in this flow chart, actually, you are seeing various types of anorectal malformations. So in this, if you see, actually, the anus is slightly anterior, and it's called ectopic perineal anus. Slightly, it is just anterior, and it is here you are seeing as if that is covered, but it is slightly it's a type of low anorectal malformation. So sometimes actually I said actually there will be fistulas. Intestines try to decompensate by taking some fistula. So usually it can be anywhere into the urethral system. So it can be into the bulbar urethra, it can be into the prostatic urethra, it can be below, lower, little bit lower down. So accordingly, I will call it as a intermediate or high. If at all, if it is opening above the prostate, we call it as a high anorectal malformation. If it is opening below the prostate, then we call it as a intermediate type of anorectal malformation. Sometimes there will be what we call it as a rectovesical fistula, where actually the rectum is opening directly into the bladder. And very rarely we'll have actually there won't be any communication. There will be just actually only a blind ending actually rectum. So that is also a rare anomaly in females. So normally the urethra, vaginal opening, and anorectal anus opening will be placed, and these two will be in the vestibule, and anal opening will be quite posterior. So if at all, if it is not placed like that, and if it is slightly anterior, then we can call it as a vestibular anus if it is opening within the vestibule. So that is the most common terminology that we use nowadays. So it can be a rectovestibular fistula, or it can be a rectovaginal fistula, or whatever it is. And sometimes actually there will be a communication into the vagina. That's what we call it as a rectovaginal fistula. So where it will be opening directly into the vagina. So child will be passing stools from the vaginal orifice. So many modifications are done in the classification only because it is little bit confusing, and little bit of misunderstanding can be there. So for better proper understanding according to the treatment wise, so in 2005 they came up with what the new classification, which is called Krickenberg classification. In this Krickenberg classification, so it is divided into major clinical groups and rare or regional variants. So in this major, actually it will be means accordingly actually we can divide it into in low, intermediate, and high types. So they can be divided into perineal fistula or erectourethral fistula, which can be either bulbar or prostatic, and it can be a rectovesical fistula if it is high up, and there can be a vestibular fistula also in a female, and cloacal malformation is graded taken considered separately, and those things which don't have fistula are separate classified separately. And the least variant, small mild variant is anal stenosis, where only the anus is little bit of smaller caliber as compared to regular one. So that is also included in this Krickenberg classification. So in rare pouches, actually something like pouch colon, which is more common in the northern India and some parts of the countries in the world, and that is what is called as a pouch colon. So where everything will be opening into actually one pouch. So pouch can be divided into four types, where the whole of the intestine is opening into one big pouch, or actually it's only some amount. Accordingly, it will be divided into four types. So rectal atresia is one condition where there is rectum which is blind ending, like almost like it will be ending blindly. So that is what is called as a rectal atresia. So there is a rectovaginal fistula, which is a H type that we discussed in the previous slide, and H type fistula also, and some others actually which can't be added into any of these conditions. They are divided as other anomalies. So I was talking some time back about 24 hours delayed picture. That is what is called as a CTPL or invertogram. Invertogram is what we used to do earlier. They used to keep a coin. Nowadays they are not keeping any metal coin or anything. Nowadays they are going only according to the bony landmarks. So cross table prone lateral, this film has replaced invertogram significantly. The main reason being it is more practical, more comfortable for the baby, and definitely safe. Because while doing invertogram, actually we'll be holding the baby like this and keeping the baby like that for some time, so that the gas will go up. So that is very scary environment for the baby. So baby will be continuously in uncomfortable position, baby will be crying too much, and sometimes it can lead to intraventricular hemorrhage as well because of the excessive crying. So that's why it is not preferred nowadays by most of the pediatric surgeons. So what pediatric surgeons are doing is they are going to put one bolster here, and then over the bolster the baby will be kept like this. So in this position the bottom is little bit higher, and automatically all the gas will start going up after the first 24 hours. And then we'll be centering it on the greater trochanter. X-ray will be short like that, and we'll be seeing actually this is what is called as a ischial bone. So in the over the ischial bone, and this is what we are seeing the pubic bone. This is what below, just below this, actually here we call it as a coccygeal line. So if it is in this line, this is called pubococcygeal line. So if it is above this pubococcygeal line, this is called intermediate high anorectal malformation. This lowermost part of the eye point, this is what we call it as a eye point. So if it is below this eye point, it is a low type. So anywhere between the PC line and between the eye point, this is what is called as a intermediate type of anorectal malformation. This is how we classify and we divide. So based on this, so this is very important X-ray in the newborn period, PC line and eye point. So if it is above or below, so for example, in this patient, you are seeing this lowermost part of the gas, it has come between the PC line and eye point. So we can call it as a intermediate. If it is above this, it is a high. If it is below this, it is a low. So accordingly, according to these lines, PC line and I line as very, very important landmarks. According to that, actually we'll be dividing. This is what I was trying to tell. It will cut this ischium bone into 1/3, 2/3 junction. So if it is above this 1/3 junction, then we can call it as a high anorectal malformation. If it is within this 1/3, actually within these two lines, then it is called as a intermediate type of anorectal malformation. If it is below this eye line, then we can call it as a low anorectal malformation. This is very important, this differentiation, because for low anorectal malformation, we'll straight away go into single stage operation, which is a anoplasty. So it is a lifetime, one-time treatment. So this differentiation is very important. So coming to the high and intermediate anorectal malformation, parents have got so many doubts. So the main doubts are about the continence, whether my child will have normal continence, whether he'll pass motions as and when required, or he'll be soiling his underpants every time. This point is very important. So if at all, if it is a high one, actually there is a high possibility that actually the child can have more of incontinence. So that's why this differentiation is very, very important, because we'll be able to prognosticate for the parents, and parents will come to a mental makeup about what to do and how to go about. So like I was telling, actually first thing a parent wants to know is my baby going to be normal like any other baby? So that is what we call it as a prognosis or prognostication of this problem. So what decides is, one, we discussed, it is a type of anorectal malformation. The other one is what we calculate and come to is sacral ratio, where if it is less than 0.4, then we call it, actually tell them that actually there is high chance that your child will have incontinence. And the quality of the spinal cord, as we talked about, the spinal sacral agencies. So yeah, based on the sacral bone, if at all if full sacrum is there, all the muscles can form, all the muscles form because of the attachment with the bony landmarks. If bone is there, only muscles can form. If bone itself did not form, then muscles will not form. So suppose if the child has got a sacral agenesis, where a significant part of this sacrum is missing, then muscles cannot form. So he'll be having only few musculature starting from here. So obviously this fellow is going to have actually higher grade of incontinence as compared to this fellow. So